We're continuing our conversation of workplace violence with today's episode topic, which is addressing verbal aggression to reduce workplace violence against nurses. This episode is a dissemination of a policy analysis of this topic, and the link is provided in our episode description. My guest is Dr. Rebecca Harris, a registered nurse and associate director in BRG's Care Transitions team. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Shimolewski.
Becky, thank you so much for joining me today.
Thanks so much for having me, Nick.
In season 2, episode 6, we had Bill Schuler on as a guest, and Bill talked about practical solutions to address workplace violence. In this episode, we're going to further examine workplace violence more from a policy perspective, with a focus on the mechanism by which workplace violence can be reduced. And so with that, can you talk a little bit about the prevalence of workplace violence?
Sure. I think that the prevalence of violence is such an important factor for nurse leaders right now. Nurses are 5 times more likely to experience violence in the workplace when we compare them to the average experience of others in different fields, second only to police officers in violent episodes in nursing. So about 1 in 4 nurses are reporting some kind of violent experience at work. That's 25%. At least 50% of those are coming from patients. So that's usually one of the most surprising things that when I talk to people about this, they don't expect it to be the patients, but in most cases, it's the patients that are assaulting nurses, whether verbally or physically. Verbal aggression is the most prevalent form of workplace violence against nurses, and it accounts for about 90% of all workplace violence. As many as 95% of nurses are reporting having experienced repeated verbal aggression at work. And the reason that this is so important is that there's a moderate correlation between verbal aggression and physical violence. So nurses that are reporting repeated exposure to verbal aggression are also about 8 times more likely to experience physical violence. The approach from a policy perspective is what can we do to reduce or to provide an early intervention during the verbal aggression that might prevent the violent episode on the back end.
The point that you're making about verbal aggression and starting early or intervening early, it makes sense. What is the impact of verbal aggression and workplace violence on stress and overall job satisfaction?
So interestingly, workplace violence, a lot of stress, job dissatisfaction, nurse burnout. Interestingly, the research shows that is more so with verbal aggression. Nurses tend to function better in short, violent episodes that are physically aggressive as opposed to repeated exposure to verbal aggression. So really looking at that, I think is important for nurses' well-being overall. So definitely a direct correlation between verbal aggression and burnout factors such as emotional exhaustion, cynicism, depersonalization. And as nurses come deeper into that burnout process, the likelihood of experiencing violence goes up. The reason for that is because they become less able to cope and respond to stress and difficult situations with patients. And then the back and forth between the patient and the nurse escalates more quickly.
And so what impact does this have on absenteeism and then the shortage as a whole for the nursing profession?
So again, back to that 75% of all missed work days from workplace violence are in the nursing and social services sectors or healthcare and social services sectors. So that's quite a few right there. And the days off for physical injury matter, but what we see even more so are those days off because nurses fear another incident will occur. They tend to stay away from work. And also PTSD and other forms. So just a generalized anxiety and trying to avoid that situation altogether. From a nursing shortage perspective, we all know that we've lost so many nurses post pandemic. So from 2020 to 2021 was the largest decrease in nursing workforce that we've seen in history, with more than 100,000 nurses leaving the workforce. Most of those younger nurses, so not just the retirees. And the suspected reason for that is not just the increased tension and stress from dealing with the pandemic and the infection and the difficulties in staffing shortages as a result, but the increased level of violence from patients and visitors that nurses were experiencing as well. So, about 30 states right now are forecasted to experience a pretty significant shortage between now and 2031.
Now, I'm going to be the skeptical one for a moment and just play the devil's advocate. I could say, you know what? There's the new Joint Commission standards that are out around workplace violence. We've got existing policies that are in place. We need to let those policies be implemented and have an opportunity to see whether they're working or not. How do we know that the current state is not sustainable?
I'm a big advocate for those workplace violence prevention plans. I think they're so important. However, they don't really prevent violence themselves, right? They really set up accountabilities for hospitals, health systems, other employers of healthcare providers to ensure that they are providing those things that will, in fact, prevent workplace violence. So the plan itself, not enough unless it's implemented and well understood and then also well adhered to going forward. So we've made great strides in that area, but still a lot of work to do. The other thing, Nick, that I think is important here is that we know that even with these policies that are coming forward, such as the TJC regulations around workplace prevention plans, incidents are still on the rise. So we're up 300% in violent incidents against healthcare workers from 2011. As I said before, nurses are second only to police officers in the number of violent encounters that they incur at work. And so we need to do more. Part of this policy analysis was really taking a hard look at what are those complicating factors that are keeping us from being successful, even as we have guidelines in place.
So, what are the complicating factors?
One of the most apparent things to me was the lack of information, particularly around verbal aggression. It's very difficult to find effective interventions that are supported by evidence in the literature to deter or intervene when verbal aggression is occurring. The policy and guidelines that are currently addressing verbal aggression against nurses are often unclear. And as I said, not well supported by the evidence. And the problem with that is that as we go look at these interventions and try to employ the interventions, we actually wind up putting nurses at risk of harm because we don't have a solid understanding of what works and what doesn't work to deter the violence in the end. Again, I think that just to give you some examples, there's a lot of conversation, particularly from the American Hospital Association, about the criminalizing violence against nurses, very similar to the kinds of criminalization that you see for violence against police officers, EMTs. The evidence, however, does not show any impact. So states with increased criminal penalties are still seeing the same rates of violence rising as other states that have not done so. De-escalation, another intervention that is, if you look through the literature, it's very prevalent, a lot of conversation there. And de-escalation tactics can work. There's evidence that emergency department nurses and psych nurses that have a lot of experience with this can do quite well with de-escalation. However, there's no predictability to it. So there's an equal amount of evidence that de-escalation tactics do not work, as there are for those times when de-escalation tactics do work. One of the noticeable differences in literature about de-escalation for police officers and education settings and nursing is that in nursing, we don't do a lot of talking about what happens when de-escalation doesn't work. Police officers have very clear guidelines for what to do when de-escalation doesn't work and recognize in a very upfront kind of way that's a likely scenario that de-escalation will not work. Same with educators, with all of the emphasis on school shootings. There has been a lot of literature produced for educators and how to respond to violence. And again, creating an expectation that de-escalation is worth trying, but likely to not work. In nursing, however, when you look at that literature, it's all about de-escalation with almost no guidance for what to do when it fails or even acknowledgement that it does fail. And it so often
There seems to be this tension that's out there around the conversation of workplace violence reduction between practical solutions that would work and balancing that against ethics, if you will. And again, seems to be this tension that exists between those two competing principles. Have you found that? And if so, can you talk a little bit more about it?
While the guidelines from law enforcement officers and security experts are very clear and very directive to nurses also about how they should respond in case of violence, then if you look over time as healthcare providers themselves had entered that conversation and produced guidelines and literature or contributed to the guidelines and literature, it becomes more and more clouded with ethical debate. The actual directives get less and less clear, and I think that is because nurses are so strongly tied to the moral obligation that they feel to put their patients before themselves. So even if that puts them at risk of harm. So the concept of acting to protect themselves for nurses may feel uncomfortable and an error. There's not a lot of training in school to respond to violence in a way that is self protective, not a lot of on the job training for how to respond in a way that is self protective. And again, 70% of nurses respond to surveys that they would definitely put their patient safety above their own if forced to choose. So I think that those ethical debates are certainly important. The foundation underneath that is really all about ensuring patient safety while under a nurse's care. But as we see the violent episodes continue to rise, we need to learn to think a little bit differently about where those ethical debates belong. So I think that continuing to have them so important, they just need to occur outside of the scope of the guidelines for safety.
All right. So let's say I'm a nurse executive right now in an organization and I'm hearing all this and I'm going, all right, what can I do? I know I have a problem, but where should I focus my efforts on on truly having an impact where violence and threat of violence is reduced?
So best questions so far, because I think that's the most important piece of this is what does work, right? What can we do? There's two things that have been proven to work. One of those is a strong safety culture. So even though safety culture originated as an effort toward patient safety, all safety culture has a very strong and inversely correlated relationship with a decrease in verbal aggression, most of all, but also subsequently in physical violence. So let me just say that one more time. There is a definite and inverse relationship between the promotion of a strong safety culture and a reduction in verbal aggression and physical violence against nurses, particularly from patients. I think that so important then that in this climate of rising violence, we need to incorporate the safety of nurses into our thinking about safety culture and really reinforce an ethical concept. So in the armed forces, they call it surviving to operate, right? Where it's really important to take care of the resource that will provide for the general welfare of the public. And so to consider nursing resources as scarce and valuable and certainly worth preserving for the long haul so as to benefit the most patients as possible, a little bit different spin on the way we think about the ethics of nursing. So typically we go for that. The patient is more important and this one patient is the most important. But as nursing resources become more scarce, we really do need to consider the benefit to the whole.
That's very helpful. Thank you for clarifying that. Now, in the unfortunate event that we do get to a situation where a violent event does occur, what should I do as a nurse executive in a healthcare organization? What does the literature say is the best thing to take care of my associates and to prevent this from happening in the future?
So, two things. And one is that initial prevention, right? So, really ensuring that nurses know not just what the de escalation tactics are, but how to recognize when they're failing. There's certain signs of impending violence that can be taught. Clenched fists are one of those, heavy breathing, sudden silence. So, there's a list of about 10 to 12 different things. Ensuring that nurses are watching for those as they attempt to de escalate patients. And if they see them, removing themselves from the situation. Of course, in a situation where there's public in the care setting, we want to take as many people with us to that safe place as possible. But as a nurse begins to perceive or sense violence is really a threat, they really need to take the time to get out. And in order to be successful with that, we need to have well-trained security professionals that are available to nurses to assist when needed. And these nurses need to know that they're going to be supported if they act to protect themselves. So a lot of surveys suggest that nurses fear retaliation if they try to protect themselves. There's a lot of evidence, again, in that incidents are significantly underreported for that same reason. Nurses are afraid of retaliation. They believe that nothing will happen if they report these incidents. So that support from leadership is going to be really key in changing the way nurses think about protecting themselves. And then the other piece that I think is important to this is, should violence occur, the evidence suggests that one of the most healing factors for nurses is a strong support from their leadership. So knowing that they're going to be supported, not just having care for their physical wounds, but also the ongoing emotional support. Those things have been shown not only to help any individual nurse recover, but to also build resiliency across the workforce so that episodes of violence have less impact overall on the workforce and the work setting. Employees can recover more quickly, get back to the important work of taking care of patients in a much more effective way. And then also that helps retain nurses too. Just knowing that they're going to be supported in their efforts to protect themselves goes a long way in their entire emotional capacity to manage in the workplace.
I know we've just barely scratched the surface of what is a very complex phenomenon. For more information, for anyone that's listening, please feel free to click on that link that's in our episode podcast description. Any closing thoughts as we wrap up this episode?
Nurse executives are in such an important position to be able to advocate for the culture and the policies that can go a long way to protect nurses in the future. And I think it's such an important topic. So again, Nick, I really appreciate the opportunity to come and talk about this.
Thank you, Becky, for continuing our discussion on workplace violence. This is our second direct episode about the topic. I suspect we will have several more episodes in the future as we continue to discuss this phenomenon and work to improve the working environment for all of our nurses in the United States and across the world. Thank you so much for joining me today, Becky.
Thank you.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.